Thank you again, and happy to share my experience with some colleagues and friends. And we're going to look at the background, which is behind the choice of the single fraction and how we get into it. So just to put it in context, this is the scenario that we faced in the last 20 years. We are witnessing a revolution. You know, we are passing from 45 treatments over 9 weeks with non-relevant severe toxicities to 5 treatments over a couple of weeks and toxicity which is 10 times lower. Okay, and in the last 20 years, we've seen, you know, in parallel running moderate hypofractionation and ultra hypofractionation with some studies that have paved the way for the use of hypofractionation. The CHIP trial with the moderate hypofractionation and the PACE trial with the ultra hypofractionation, and you can see that there are already some prospective trials who look at the possibility of using the single fraction at least in selected patients. So this is what is written in the tabloids. Prostate cancer can be cured in 1 week, but maybe behind the corner that can be the opportunity to treat in 1 day at least in some patients. And this is now what the guidelines recommends, to use ultra hypofractionation, which means prostate SBRT, almost in every setting in the treatment of prostate cancer. But what I mean, the level 1 evidence for prostate SBRT comes mainly from these seminal trials, the PACE trials, that proved the non-inferiority of prostate SBRT for low and intermediate risk prostate cancer. Results of this trial were published recently. We all know that the PACE trials are an umbrella trial. The PACE-B randomized patients to prostate SBRT, 36.25 grain 5 fraction over a couple of weeks, compared to conventional fractionation, and in the meantime, moderate hypofractionation became the standard of care and became the control arm in this trial. And we can see now the 5-year results, and the non-inferiority of prostate SBRT was proven compared to conventional radiotherapy, with excellent results exceeding 95% at 5-year in terms of biochemical failure, which was the primary endpoint. And this is extremely relevant because when scrutinizing the data, we can see that most of these patients were actually considered unfavorable, intermediate unfavorable according to NCCN definition. And so achieving such a good results with prostate SBRT and non-using ADT is really considerable. And also the results in terms of toxicity was extremely good, with 5-year G2 toxicity or higher absolutely good for GI, and also for GU there was no difference at 2 years in terms of G2 or higher GU toxicity, although at 2 year the GU or higher G2 toxicity was significantly higher with hyperfractionation, and we're gonna see why it happened. The other trial was the PACE A, same patient population, low or intermediate risk. This is what Professor Johannes called the battle of robot, because it compared the robotic prostatectomy against the prostate SBRT, mainly done with the robotic arm of cyberknife. So the best of surgery compared to the best of radiotherapy, and the results are pretty clear in terms of incontinence. The 2-year rate of incontinence, meaning patients need to wear at least one pad per day, was 50% in the surgery arm, and almost 10 times lower in those treated with prostate SBRT. And also the sexual function was much more impacted with prostatectomy compared to prostate SBRT. So, although many surgeons still don't believe this result, they cannot stop the wind with their hands. I mean, it's clear enough that in terms of quality of life, at least in the short, medium term, at 2 years, the toxicity profile was far better with radiotherapy rather than the best of surgery. And this might explain why still there is an high regret with surgery. Almost 1/3 of patients treated with robotic surgery regret of the treatment they have received. So, but why we need to dose escalate with SBRT? These are the result of dose finding trials from Memorial Sloan Kettering, and we can see here that the biopsy outcomes suggest improved rates of tumor clearance observed with higher dose. So indicating that higher dose may be required for tumor with some high risk characteristics. And also we see that those who had positive biopsies at 2 years did worse in terms of biochemical failure. So there was a strong correlation between the positivity of the biopsies at 2 years and the rate of biochemical failure. And again, and also the 8-year incidence of PSA failure was 20% for the low dose group, and 4 times less, 5%, for the high dose group. So meaning that we need to push the dose to increase the disease control. And from the same group, they demonstrated that most patients with positive biopsies after prostate SBRT had residual disease found within their initial Pirates 4 or 5 dominant lesion. So these results suggest that focal dose escalation with higher radiation dose can improve local control. And this was proven by the hypoflame trial recently published. So 35 gray in 5 fraction to the whole prostate with a focal tumor boost up to 50 gray. And the results are amazing. It's 93% of 5-year biochemical disease-free survival, which is considerable in view of the fact that most of these patients were at high risk, and 40% of them did not even receive ADT. When we need to escalate the dose, we need to take into account some risk, and some of these are patient-related factors which can predict the risk of GU toxicity, and these are large prostates, prior urethral resection, high baseline urinary symptoms, IPSS more than 15, and the length of the urethra. This study was recently published and found that the urethral length is a factor which is independently associated with an increased risk of GU toxicity. And this can be simply assessed by looking at an MRI on the sagittal planes. So we need to select patients properly for escalating the dose with SBRT. And there are also some treatment-related factors. And among all, there is the dose to the intraprostatic urethra. And why is that? Because the intraprostatic urethra is a healthy organ laying inside our target, the prostate. And this meta-analysis of 23 prospective SBRT clinical trials demonstrated a close correlation between the radiation dose delivered to the intraprostatic urethra and the development of GU toxicity, and namely that the maximum, an increase of 1 gray to the dose to the urethra is associated with a significant risk of both late and acute toxicity. And this is irrespective of age, prostate size, baseline urinary function, and bladder dosimetry. And independently from the radiation schedule, by limiting the maximum urethral doses to 80 to 85 gray in terms of AQD2, the cumulative incidences of late G2 or higher toxicity are expected to remain below 20%. So any approach trying to limit urethral doses are highly encouraged in future clinical trials to reduce both acute and late GU toxicity. And surprisingly, at the edge of this spectrum is the phase B trial. And why is that? Because this is due to the typical dose prescription in this trial. For SBRT, we see that the dose to 95% of the PTV was 36.25 gray, with a secondary objective of a CTV coverage of at least 40 gray, and the dose heterogeneity allowed within the SBRT targets was, permits maximum doses of more than 45 gray, which means exceeding the AQD2 with alpha beta ratio of 3 of 100 gray. This might explain the increased risk of G2 or higher toxicity at 2 years, which was significantly higher compared to the control group. So ideally, we should try to keep the dose within the intraprostatic urethra below 90 gray in terms of AQD2 with alpha beta of 3 gray. To not to increase the risk of GU or higher toxicity more than 20%, which is considered acceptable. And if you don't do it, what happens? This is proven in these two trials, the 2STAR and 2SMART. This is the pooled analysis. Patients received 2 fraction prostate SBRT with a boost to the DIL up to 32 gray in the 2SMART trial. There was no constraint on the urethra, so you can see that this fractionation corresponds to an AQD2 with alpha beta 3 of 134.5 gray, which is far, high than the threshold for expecting a low toxicity. And indeed, both the acute and the late GU toxicity was as high as 60%, so unacceptable high. While on the other hand, if you spare the dose to the urethra, you can deliver even a single dose of radiation to the whole prostate, not exceeding the GU toxicity. This is 19 gray to the prostate with 17 gray to the urethral PRV. In terms of the AQD2, we are within the recommended threshold, and indeed the GU toxicity never exceed 20% in this trial. So the safe delivery of fewer high-dose fractions requires reduced margins, and in order to do it, we need an intrafraction motion mitigation, because prostate may move with displacement up to 1 centimeter observed during the single fraction. And this is a proof that if you can safely reduce margins, you can expect a lower risk of toxicity. This is the 2-year result of the MIRAGE trial, which randomized patients to be treated with CT arm versus MRI arm, but actually was a trial comparing 2 different margins, 4 millimeter with the CT arm and 2 millimeters with MRI arm. And when patients were treated on MRI machine, you see that the GI toxicity was negligible, and the late grade 2 or higher GU toxicity was the halved with when the margins are reduced. So under these circumstances, we designed this trial of single fraction for prostate SBRT. You can see here the trial outline. We treat a patient with 24 gray single dose to the whole gland in combination with ADT as per standard of care, meaning no less than 18 months. Patients were simulated with MRI, and then they were treated on a LINAC platform with a VMAT technique and triple F modality, and with a real-time tracking ensured by Raypilot. And you can see here the patient characteristics. Patients were highly selected. You can see that the median IPSS at baseline was 6. The median prostate volume was 38. Most of these patients were at high risk, organ confined, and almost everyone received ADT. And you can see here that the dose to the PRV, meaning 3 millimeter from the organs at risk, was kept to 80% of the prescribed dose, which means that in terms of AQD2 with alpha beta 3, the total dose delivered was 85.5 gray, so still within the recommended threshold of 90 gray to keep the GU toxicity as at lowest possible levels. And you can see the dosimetric plans on the axial and coronal planes using a fused CT MRI image. And the color wash dose distributions are shown with the threshold of 80% of the prescription dose. So the blue line is 19.2 gray. And you can see the conformal avoidance of the organs at risk and the urethral sparing effects seen by inverse dose painting, looking like a hole inside the gland. We treated 30 patients. You can see here some characteristic on the treatment delivery. Median treatment time was 14 minutes, which is the normal times of any slot that we allocated for every patient treated on a Linac platform. The median beam on time was 4.3 minutes, which is significantly lower than any prostate SBRT treatment on any other facilities. And treatment interruptions were required in 57 of the session due to at least one prostate displacement more than 2 millimeter, which is the margins that we gave for the PTV. So whenever the prostate exceed 2 millimeter displacement, the Raypilot was able to detect the displacement, the beam was interrupted, and if the displacement was confirmed, we asked for a second combined CT to reset the setup. And you can see here the result with a median follow-up of 18 months. No G3 or higher toxicity was found, nor in the GU or GI domain, which was the primary endpoint of the trial. And we found just a couple of patients experiencing an acute and late GU toxicity, mainly consisting in urgency, which resolved with modest supportive care. And also in terms of quality of life, there were no significant decline in patient quality of life in any domains. The only domains which was significantly impacted was the urinary domain. But you know that using questionnaires, even small differences can identify significant changes. So whether the observed change in the minimum important difference score represents trivial or relevant change remains a challenge. And actually, this patient never experienced a relevant GU toxicity. So just to conclude, in my opinion, high quality prostate SBRT requires careful patient selection, high resolution imaging, and mainly MRI to look at the relationship between different organs and different substructures within the same organ. For example, the bladder trigon or the urethra. Dose escalation is needed for tumor at higher risk. Monitoring and correction for target motion and decreasing the dose to some structures, and namely the intraprostatic urethra, are mandatory. And this is where some tools like Raypilot can really make difference. And finally, a quick delivery time, which is very important to minimize the risk of an intrafraction organ motion. So with that said, I thank you very much for the attention.
Thank you very much for the introduction. That was a great talk, Stefano. Thank you. We'll touch on some of what you've covered on, but I'll try and bring a slightly different emphasis. So PACE-B and what comes after it and why we need the precision study. So we've seen these results already. We're all very reassured that SBRT looks to be fantastic from a control of cancer point of view at 5 years. Obviously, longer-term data will be quite important as we follow up for longer, but I think it has become standard of care now for favourable intermediate risk patients in the UK. Right, next slide. So when we look at PACE-B, though, what really has interested me quite a lot has been the toxicity associated with SBRT. So the takeaway message was that there was no difference. So everyone was quite reassured. So no difference in GU or GI, grade 2 plus toxicity. But when you break those figures down a little bit more and look a little bit more closely, you can see that the genitourinary toxicity was significantly different whether you were treated on a CyberKnife versus a linear accelerator. So a third of patients virtually treated with a linear accelerator had grade 2 plus GU toxicity acutely. And I think that's quite a significant finding. And a third of your patients go on to have quite significant toxicity, because this is what that means. Basically, if you've got grade 2, you're peeing 12 to 16 times a day. You might be up 5 to 8 times at night. You can have dysuria, urgency, bladder spasms, significant amount of toxicity. And even grade 1, I mean, I had an old colleague, I've said this before, who said, well, why do we accept any toxicity? Grade 1 toxicity would change a patient's behavior. He may not go out while he's got these acute symptoms because of being caught short, traveling out into the town, for instance. So I think it is important to reflect on toxicity as an important endpoint, particularly because we know survival is excellent. These patients tend to do very well with treatment. So the late figures, yep, we all say, well, acute toxicity doesn't matter because, it's really late toxicity is the one that really affects the patient. And again, from the PACE-B group, they basically reassured everyone saying, look, GU and GI significant toxicity, grade 2 above, is really exceptionally low. Recently updated 5-year data does suggest that perhaps there's an uptick in GU toxicity, with over 5.5% of patients now noticing grade 2 or above, which is, 1 in 20 or so of your patients suffering this, which would be hematuria. So grade 2 would be moderate frequency, telangiectasia causing bleeding. So every time a patient has blood in the urine, they have to go through the hematuria pathway here in the UK. It's expensive, it's time consuming, it provokes a lot of anxiety and a lot of investigations for patients, affecting their ongoing quality of life. And this is what it looks like. So here we have urethral telangiectasia. So these little broken blood vessels, this is the trigrone, the bladder neck going into the urethra. So you need to try and avoid this, because this is really what radiation does. It causes these microvascular changes which bleed. And here's rectal proctitis with telangiectasia. So we need to avoid both of these if we possibly can in a group of patients who we really would hope to be curing. And the PACE-B group published this data saying, well, actually, acute toxicity does predict for late toxicity. And this is something that I had been sort of feeling for a long time. I was very gratified when these kind of publications came out and sort of supported your own biased view of this, really. So I won't go through this in any great detail because of time, but when we look at the multivariate analysis for any late grade 2 plus GU toxicity, having bad baseline symptoms before you treat somebody is not a good thing to do. So like in Stefano's trial there, exclude patients who have significant baseline toxicity. They won't be happy at the end of the day. But what was also very notable was your worst acute grade 2 did predict for late toxicity. Highly significant, with an odds ratio of 3.7, p-value, as you can see, very low. What was also quite striking was the fiducial markers and being treated on a conventional LINAC rather than the CyberKnife. The original PACE-B cohort were CyberKnife centers only, then rolled out to LINACs, did actually predict your risk of GU toxicity. And we'll come on to why we think that is in a moment or two. For GI toxicity, again, your worst grade 2 predicted. Understand if fiducial markers drop out, because why should they affect your rectum? And your LINAC didn't seem to make such a difference. And I guess it's not a surprise. We saw that the GI toxicity is exceptionally low, 2%. It's really not considered a major issue. So concluding from these kind of data, it would say that if you have bad baseline GU toxicity, that this would predict for late, so therefore avoid treating patients with SBRT in this group, or temper expectations if a patient really has to be treated with SBRT, that they still have symptoms. Acute toxicity predicts for late, therefore we should try and reduce it. And we'll talk again around sparing the urethra and obviously trying to limit dose to the bladder. Acute GI toxicity predicts for late, so keep your posterior margin tight. We saw that from Stefano's data there, showing that a 2 millimeter posterior margin was far better than a 4 millimeter one for GI toxicity, probably unsurprisingly because you're treating less tissue. And why use fiducial markers? It's not clear why toxicity was increased with fiducials. It could be a dose effect. It may just be to do with the fact you're treating on a LINAC. And obviously, the vast majority of patients are going to be treated on conventional LINAC accelerators. We don't have CyberKnives, we don't have MR LINACs, certainly in the UK in many centres. So therefore, is this a tracking issue? Is it a dose distribution? Is it the margins that we used? And what was particularly interesting, again, from the same group in Marsden, they looked at the fraction size and toxicity from the CHIP trial, looking at what is the alpha-beta ratio for the urethra. So we've assumed it's been 3. Well, it looks like it might actually be as low as the prostate, 1.5 to 2. So as we saw there, with pushing the dose into the center of the prostate, in reality, your EQD2 dose is probably 100 to 109 gray, which would certainly increase your risk of toxicity. So we really do need to think about the urethra as an organ at risk, which is something, I did a lot of LDL brachytherapy throughout my career, and we were always very cautious around the urethral dose. We knew it was there, we could visualize it, we wanted to keep it down. I think what we've seen is that as external beam doses start to increase in their biological effectiveness, and the EQD is now approaching those kind of brachy-type doses, the urethra is suddenly at risk, and people are just cottoning on to that in the external beam community. So here's a typical plan. This was actually one of our printout patients that we did. You can see beautifully conformal around the rectum, but we're pushing 40 gray right into the middle, into where the urethra sits. So we were not aware where the urethra was. We probably weren't even thinking too much around the urethra when we were doing the original patients within PACE-B. So Precision is a study which has grown a lot of interest and arms and legs really over the last few years, which is about to open here in Edinburgh properly, and you're all invited as any Raypilot Centre to join this study. It's a phase 2 study of 3 fractions of prostate SBRT using Raypilot for the same patient group really as PACE-B. So we know that the LINAC is the most commonly used method of treatment delivery for extreme hypofractionation, so we really want to optimize its performance, and we feel we can do that using the Raypilot to give us tumor tracking, with the hypercath in particular allowing us to identify the urethra. We need tighter margins, which comes with tracking. We need urethral sparing, which comes with the hypercath. And this gives us confidence that we're going to hit our target accurately, which obviously will limit surrounding dose to normal tissue and maximize tumor coverage. And obviously having a catheter in situ for any length of time, and we've been using it for quite a while, and we treat over a 7-day period with weekend break. We always felt the men after the weekend of having the catheter in were ready to take it out for the last 2 fractions of their treatment. They really had about enough of it. So let's keep it as minimum as we can. So we thought, well, 3 fractions, that's just 2 nights. That's very minimal inconvenience to a patient. And we wanted to base this study in terms of toxicity, because it's a phase 2, on the data from PACE-B. And we also wanted to test the experimental hypothesis of whether urethral sparing does actually reduce acute and late grade 2 plus urinary toxicity. And also it's a great way of us all being brought together, creating an evidence base for extreme hypofractionation. So this table here just shows the prostate ISO effectiveness. So from PACE-B, you can see 36.25 to the PTV and dose escalation to the CTV, effectively the prostate, giving us this magic figure of 100 to 109 Gray equivalent. So anything over 100 is thought to be potentially ablative. And in precision, we've done exactly the same technique. So 28.5 Gray and 3 fractions to the PTV with 31.5 Gray and 3 fractions to the CTV. And this brings us up to really iso-effective tumor control doses to PACE-B. When it comes to toxicity, same thing. We're really pretty much iso-effective, assuming alpha beta ratio somewhere in the region of sort of 3, 4, 5 for rectum and bladder, and originally for the urethra. But this came out, as you saw, with the fraction size from the CHIP study suggesting that alpha beta ratio for the urethra may be a lot lower. So in PACE-B, just to emphasize again, the CTV dose was really the urethra getting somewhere in the region of 100 to 109 Gray equivalent. In precision, we're basically making a relative sort of PRV. So the PTV dose is 28.5 Gray, which is the maximum that urethra would get. But in fact, when we've been running our test plans, we're dropping this dose down in the region to 25 Grays. So even with the worst case scenario that the alpha beta ratio is as low as 1.5 to 2, we're comfortably below 85 Gray in the 64 to 70 Gray range. Obviously, if the alpha beta ratio is 3 or so, we're much, much lower again. So we feel pretty confident that with the doses that we've done, with the planning techniques that we've recommended, that we should be able to see some reduction in urethral toxicity. But obviously, the trial will show us. So here's a typical plan with, a cold center, so with the hypercath in the center here with the relative PRV. And then you can see here in the sagittal view how you can really drop the doses down quite significantly, which is nice to see. So really quite an attractive plan from an oncologist point of view. So here's the color wash. So we're down to about 25 Gray in the center. So this would be the hypercath with a margin grown for your urethral wall and a further margin of 2 millimeters for the PTV. So we think that with this relatively cool center, obviously nice conformal dose around the edge of the prostate here, we should be able to keep our doses down to in the region of 25 Gray as an average. So here you go again with the sagittal view. So coming really just towards the end, this is just a cartoon. So we have our catheter as a 6 millimeter circle. The urethral wall is thought to be 2 millimeters out with the catheter. So you add 2 millimeters, and then you add a further 2 millimeters for the urethral PRV, which is the urethral wall plus 2, and that would get a dose maximum of 28.5 Gray. But really in the center here with the dose gradients that we can see with triple F planning, you can comfortably keep it down to 25. So we're pretty confident that even with a little bit of movement, from setup inaccuracies, we should still be able to limit the dose to the urethra to very low acceptable levels. 100 patients in total. We have stopping rules built in if there's too much toxicity. They're co-primary endpoints. I'm really hoping that we don't fall foul of GI toxicity when we do this, because if one or other tips, then we have to stop. But let's assume it all goes smoothly and we manage to declare that a 3 fraction schedule is safe, that we're not seeing excessive GI or GU toxicity in the acute setting. So really, this is where we're up to now with our first test case our first case has been booked for early in the new year. We had hoped to treat pre-Christmas, but I'm sure anyone opening trials realizes how many hoops that you have to jump through. But we're all going to be working to this shared REDCap database. So if you were to open, you'd open it under your own local sort of approvals, but we all would be entering our data into the shared REDCap database. And one thing just to touch on, which has been a great initiative here in Scotland, is Scotland's really bought into this now, which is fantastic. So 4 out of our 5 cancer centres, NHS Highland at the moment hasn't agreed to join the study. They will be joining us, which is really great news. So we're really quite excited about that. And I think that will about wrap me up. Hopefully, that obviously happy to answer any questions at the end. And I will hand over to my colleague, Joe. Thank you very much. Thank you.
Thank you for the introduction. And hopefully I follow on quite nicely from all the information we've had so far with a bit more of a practical look into the use of Raypilot and what it's meant for us as radiographers, or RTTs as we're known elsewhere. So my name is Jo Mitchell, and I am the Principal Research Radiographer here in the Edinburgh Cancer Centre. I'm doing a PhD looking at the clinical implementation of adaptive radiotherapy, but I've primarily been working with patients who have been involved with the Raypilot device, and that is initially as part of the printout clinical trial, and then obviously as we move forward as part of Precision. So like I say, this is going to be a bit more of a practical demonstration of what we've done as radiographers. So our story so far, we've been involved with Raypilot. We treated our first patient back in 2018. Now, what this has done for us as radiographers, the more you see, the more information you get, the more things you need to act on. And where do we fit in the adaptive cycle? Well, we're the people who are switching on and actually delivering that treatment. So really, it doesn't matter what you've done on your planning, how much detail you've got there. If your patient's moving, it's what we are delivering and to where is what's important. And as we all know, with prostate radiotherapy in general, the organs at risk massively can impact what happens to the patient. So initially, we just had a look at the first 9 patients that we treated using Raypilot, using sort of the information we got with motion, the time that it was taking us to deliver the radiotherapy, and all the cone beam CTs that we were actually gathering, which gave us a lot of information. And we looked initially at the rectal volume and the toxicity patients reported during the printout clinical trial. We only had 9 patients in this study, so we didn't actually find any strong correlation. But what was very clear is just how much things are changing. Following on from this, we then had a much deeper look at prostate in a fraction motion in general. And this resulted in a paper that we had published in TIPS-RO on the clinical implementation of real-time motion management for prostate SBRT, but how this affects us as radiation therapists and what it means to us. So like I say, using Raypilot, but also all the images that we take in combination, and bearing in mind, we've used the device from the beginning. So we've been able to see how sort of things change with when we had the device initially inserted directly into the prostate gland, and now as it's fitted as part of a urinary catheter. And I think these images perfectly sort of show. We ask patients to have a comfortably full bladder. That's what we do here in Edinburgh. And actually, it never sort of replicates how it is on the plan, and it varies a lot. And you can see, so this is demonstrated in this image here. And obviously, having a catheter in, you can really standardize the bladder. And so we wanted to have a look and see, well, is that actually really impacting the motion of the prostate? We know primarily the motion tends to be supinf and antepost. And what bearing is that having on the dose we're delivering to the prostate, the bladder itself, and also the rectum? And you can see these are sort of the images that we've gathered over the course of the treatment and how much movement that you can actually see. So in the paper, what we looked at, we sort of tried to test every condition, all the outcomes that the patients were reporting, all the toxicity, the displacements of the device. And I mentioned before, primarily, we tend to think, I think as radiographers, motion tends to be in the supinf direction and the antepost direction. And actually, in our study here, what sort of come up as significant was actually lateral displacements and the toxicity that the patients were reporting. This was on the first 18 patients that we treated as part of the printout clinical trial, the first 9 patients having the device inserted transperineally, and the next 9 having the device inserted as part of the hypercath device. So there's still more questions to go. This was acute GU and GI toxicity. So again, we've got further work to do to clarify sort of is motion, how does this impact the decisions that we're making when we're switching our linear accelerators on, and what we need to consider to make sure that we can actually deliver that dose that we see on the plan as accurately as we actually need to. We've heard here that we want to push the dose. We know the prostate's going to respond to pushing the dose, but actually patients move, and patients move all the time. And it's no good if actually we've not delivered that dose where we need to be. So what are we doing now? Well, obviously, we're all going to get ready for the precision protocol. And we've also heard that we want to push the dose, but we want to spare the urethra. Now, we've had a little look here at how much the urethra is moving, because this is another structure that also moves. I think radiotherapy would be lovely if patients didn't move at all, but if you've got a living, breathing person lying on the bed, it doesn't matter what we do, how much preparation, they are going to move. So we need to try and make sure we take every bit of information we can and try and deliver that dose as accurately as we possibly can. These are patients that we treated as part of the printout study, the 9 patients that we looked at. But as you can see on these images, they're not the best images, but you can see here the difference in sort of the position of the urethra in this green contour and the yellow contour. And this is between the time it's taken us to switch the machine on and off, but also in relation to where actually that dose has been delivered as a planned volume and what we think we are delivering. Appreciate that these do look like a mixture of contours, and it's quite fluffy, but this does show that, again, this structure is moving throughout. It's moving interfractionally, and it's moving from the beginning and the end of your course of treatment. So we've heard it's the new kid on the block. It's potentially it's directly correlating to GU toxicity. And now, because of Raypilot Hypercath, we can see this on our cone beam CT images. We were never used to be able to see it when we're delivering treatment on a linear accelerator. We could never see it. And as with anything, as sure you can see it, we need to act on that, and we need to factor that in as radiographers, as radiation therapists. We need to factor this structure now into our decisions when we're switching the machine on. So it isn't a structure, like I say, that we normally think about, but this was just picking one patient out of our cohort that we looked at. This was the difference in the volume of the urethra that was receiving 36 gray. On the planned volume, that was 0.35. That was what was initially planned. On one fraction, the first cone beam that we took, the pre-cone beam CT, we were delivering 36 gray to 0.96 cc. But on the post-cone beam, that had changed to 0.78 cc. So again, if we want to push the dose, we want to spare the urethra, we really need to know where the urethra is to try and give us the best shot. We also, like we said, we've heard we need to deliver the treatment very, very quickly. But even if you deliver the treatment quickly, there is still going to be motion. So what are we doing here in preparation for precision? It is not something that we routinely do, that we need to factor in the position of the urethra, but we're going to have to. And like I say, we can see it, so why shouldn't we? We've got that responsibility to deliver this dose very, very accurately. I think Professor McLaren's already touched on this, but we are going to be delivering a different dose over 3 fractions. Now, we don't have any room for error. We don't have any room for actually saying, well, we can treat today, we'll wait, and we'll not treat tomorrow, and we can take advice. We need to be able to take the right action at the right time. So we have, and we're not going to be using fiducials as well here. We're going to be doing soft tissue volumetric image matching, which again, here in Edinburgh is a new thing. We have been using fiducials. So what we thought we would do is we'd do a little study to just test how feasible it will be, how easy this is going to be to train a small group of staff to be able to do this image matching to the prostatic urethra nice and accurately. So this was the project that we have just undertaken. We wanted to use all pre-treatment cone beam CT images from the first 10 patients that we treated as part of the printout clinical trial. We all have all of these images stored and fitted using the Hypercath device. We've rematched all of those images to take into account the urethra as an organ at risk. These images were previously matched using fiducials. The objectives is to assess the feasibility of undertaking this match online. So how easy that's going to be. Are we going to be able to do it nice and efficiently? Because we need to, because the longer the patient's on the bed, the more movement we're going to see. But then after that, to see if we can detect any difference in the planned dose and the actual delivered dose, and see if there's any difference in the delivered dose ultimately to the PTV, the rectum, and the bladder as a result of matching to the urethra. So these were the guidelines that we set for our cohort of radiographers that were involved in our study. We wanted them to soft tissue match to the prostate gland using 3 degrees of freedom, ensuring that our prostate gland fell within the PTV. They were then instructed to shift the images in an AP direction to match the urethra on the cone beam CT to the urethral volume that was on the original planning data set. It was then they just had to confirm that this match was satisfactory or a best fit in all 3 planes, because the urethra, obviously, it's not going to fall perfectly every time. They then were recording the match coordinates that they matched to following these guidelines on a study spreadsheet. And then we also asked if they could document if they felt this match would be clinically acceptable using a scale of 1, 2, 3, where 1 is not clinically acceptable and you wouldn't be treating. 2, they are not sure and they potentially would be needing advice. Or 3, yes, they felt that this would be perfect and they would carry on and treat. And also any other comments that they could think of to just give us enough information to then build potential a process that we could then roll out. So we asked 3 experienced radiographers in the department with image matching experience to match these images independently. All 3, following those guidelines, all 3 matched every image. There were 10 patients, 5 images per patient, so 50 images in total. They were all rematched, and every image they rematched to within 0.8 of a millimeter. They all gave similar levels of agreement in the scores, whether they would treat, take advice, or they weren't happy to treat. And the queries that they gave us were all focused around the rectal volume and PTV coverage. So we felt that that was something that we could then work on to take this forward. As a verification method, we then took the spreadsheets back, we anonymized them, mixed them up and handed them back, and asked each RTT or radiographer to verify each other's results. They didn't know who they were verifying, and we asked that they do this independently as well. It was stressed that this was not a test of how good their image matching skills were. This is a test of this new process. And they verified them against the coordinates on the spreadsheet, and again asked to score for suitability and add any comments added. And these were the results that we had. Most images, they did say, were clinically acceptable. The initial first round, where they independently matched for themselves, they gave the sort of highest scores with 78%, 86%, and 74% of all images matched, saying they would clinically accept. So we felt that feasibly it is something that we can do. On the second look and on the verification, scores differed a little bit more, with 86, 92, and 74% of those images deemed to be clinically acceptable. But again, all comments throughout were very much based on the rectal volume and the PTV coverage. So where are we going to go now? Well, in the clinical setting, we want to take these findings and try and integrate these into our documentation and support the wider RTT radiographer training, which will allow us to implement the precision clinical trial and take that forward. So we feel that we do have enough to work on, to teach and use this as a training tool to allow us to do this quite efficiently in the clinicals, quite efficiently and safely in the clinical setting. And hopefully we can see not the problems, but what maybe questions, what are going to come up with when we've got a patient actually lying on the bed as well. From a research point of view, we want to have a bit of a deeper investigation into the changes that the position of the urethra makes during treatment delivery, and also see, is there any correlation in the positional changes that we're seeing to the patient reported outcomes. And that, I think, that is me. Thank you very much.
Thanks. Welcome, everybody. I hope you can see my slides.
Yes.
Perfectly. So yeah, thanks for letting me present you the results from our little study we did in Salzburg. So this presentation ties wonderfully with the topics Joe told us in the previous presentation. So together with my advisor, Professor Wolf, we looked at ways to improve prostate irradiation workflow. And with our study, we wanted to answer the question if the hypocath can substitute the gold markers which we use at the moment for prostate IGRT. So maybe this is a little bit more appropriate title slide, because our motivation is to get rid of the gold markers. As you all know, with the introduction of the prostate UHFX, it is increasingly critical to ensure that the prescribed dose reaches the target volume. In our clinic, at the moment, state of the art involves the use of gold markers, which are invasively implanted into the prostate, at least if the urologist places them correctly. But however, the gold markers, as we all know, have several downsides. For example, they can lead to complications such as rectal bleeding or infections. And also imaging with gold markers only provide a snapshot in time. So the prostate is a highly mobile organ, as we all know already. So it doesn't help a lot when you have to deal with a highly mobile prostate. So this is where the Raypilot HyperCath becomes relevant in our clinics, and the aim of our study was to evaluate the interfractional as well as the intrafractional stability of the HyperCath and the in situ accuracy. So our study design consisted of 12 patients, which were each treated with 6x6 gray. The HyperCath was used placed prior to the planning CT. So in total, we had 64 fractions collected. We used KV imaging in combination with gold markers. And all the patients in all the patients, the HyperCath catheter was secured with a stabilizing knot you can see here highlighted in this image. Data collection. So the motion data for each fraction was stored in an SQL database and visualized using a Python script. And the graph here represents a typical fraction with 2 VMAT arcs, and so how you can read this this diagram. So the black curve here is basically the resulting motion vector of the prostate. In the colored lines are the 3 directions, and this motion is here shown as a function of time. The vertical black line pairs are a KV image pair, and the blue shaded area is actual beam on time. So how can you interpret such a plot? So in this case, for example, the patient was initially aligned to skin markers, and simultaneously with getting the first KV image, the system was nulled. And then already when performing the image matching, the prostate started to drift away continuously, mainly in the vertical direction. So after the first arc, we decided to wait and see if maybe the prostate goes back to its original position, which didn't happen. So this is why we redid patient positioning. So the system could be nulled again, and the second arc could be delivered without any further issues. What we also did with all the fractions was acquiring a last KV image pair after the arcs have been delivered for quality assurance. So with stored data, this also allowed us to take a look at hypothetical fractions. So the answer is basically the question: what would have happened if we would not have used the Raypilot HyperCath? And those simulations, they highlight basically the benefit of using the HyperCath by illustrating how prostate motion would have affected treatment quality without live adjustments. So this was the motion data stored in this SQL database. On the other hand, we had all acquired a lot of images. The motion data was then paired with the KV images, such that for the axial stability, we superimposed the KV images acquired at 180 degree. So this allows us to answer the intra-fractional stability, because one assumes that the catheter mainly moves in the craniocaudal direction. And we also used the image pairs to evaluate the accuracy of the hypergraph measured motion compared to the KV image, KV images using timestamps. So all in all together, as I said in the beginning, we acquired 64 fractions with these 12 patients, 21 treatment interruptions occurred during this period, where 8 of 12 patients required at least one interruption. So this gave us a mean treatment time of 9 minutes, of which a bit more than 3 minutes was initial setup due to imaging and matching. Half a minute was due to technical issues such as the gantry rotation or collimator rotation between the arcs. 1 minute and 15 seconds was due to interruptions, and only 4 minutes was actually beam on time. So when looking at the benefit, it is important to see that it is highly dependent on which patient you look at, because some patients did not benefit at all from the hypercap because they had very stable prostates. On the other hand, there are some patients which benefited a lot from it. So to highlight this, I took the 3 patients which benefited the most from this 12 patient set. So for example, patient 1 would have been almost half of the treatment outside of the margin with his prostate. So you can see that maybe it's not for all patients relevant, but those who benefit from it benefit really a lot from the hypercap. So now let's look at a little bit at the technical aspects. So the difference between the hypercap and the Goldmarker IGRT measurements. So as expected, the difference between those, let's say, image modalities is centered around 0 with some outliers with up to half a centimeter. But we have to keep in mind that that the discrepancies likely reflect the data validity rather than the measurement accuracy, because as I mentioned before, we need timestamps to match the transmitter and the Goldmarker, the transmitter motion with the Goldmarker images. And you have to really get the timestamp right so this fits together. And another source of error is also maybe the catheter slippage, primarily in the longitudinal direction, as you might expect. And you have to keep in mind that you assume a perfect match and perfect table shifts with this evaluation. Also, I need to mention that we did a lot of phantom testing with the hypercap. So we built a little phantom where we placed a catheter inside and glued some gold markers on it. And here we had a perfect match for every move we did with this phantom. So all those maybe outliers are basically due to a poor timestamp match, or due to assuming that you do a perfect match, or that you assume that the KV images are perfectly. Another thing we looked at is, as I said in the beginning, the intrafractional stability. So the analysis of the coronal plane showed some outliers again. So we had a lateral outlier with up to half a centimeter, which is not really rational, because you don't expect that the catheter slips lateral in the urethra. So again, this is just a hint that you have to be aware that data acquisition is not that easy. On the other hand, craniocaudal mismatch could be actually identified with a patient. Actually, this patient reported bladder cramps, so those outliers here can be explained with the bladder cramps. However, when looking at the interfractional stability, as expected, it is a little bit less precise than the intrafractional stability, but nevertheless, the catheter position is reproducible as expected. So I think for the end, I want to go through some other things which caught our attention when we worked with those patients. So what we noticed is that prostate motion occurred in a huge variety of motion patterns. So some prostates were really stable with movement from less than a millimeter during the whole fraction, whereas other prostates had a lot of bouncing movement, which could be periodic or not, and some even could shift up to 1 centimeter in a couple of seconds, like for example in this patient. And these variations were whether they were not they weren't patient specific, and they also weren't fraction specific. So it could happen that the patient which had very stable prostate for, say, the first two fractions displayed such a movement like this here. In the third fraction and in the fourth fraction, movement could have been settled again. But there are some other key takeaways which we found, so which we want to keep in mind for the future. So, for example, imaging takes a lot of time. This is why we chose KV images, not the common CT. Also, image matching takes a lot of time. Compensating prostate movement directly by controlling the treatment couch directly by the Raypilot would save a lot of time. For example, when you look at this graph here, where a patient was treated, it took approximately 12 minutes or so. And as you can see, for example, image matching already took 2 minutes, and yeah, we need to reduce this time. What we did not use was FFF. We are going to implement it in our clinics in the next 2 or 3 weeks, so we can get rid of this maybe small area here, but it's not the biggest piece of cake, because imaging is basically the thing which consumes the most time. And as Jo already mentioned in her presentation, the more you know what you're doing wrong, maybe. So after evaluating 12 patients, we wanted to switch to the 5x8 gray delivered to the CTV with urethra sparing. Initially with gold markers, and here we filled the blocker balloon with contrast to better visualize the urethra in the common CT. But however, the urethra sometimes differed significantly from planning CT. This is rendering urethra sparing ineffectiveness. So maybe a possible reason is that we over-tightened this knot we did to originally with the motivation to fixate the catheter as good as possible. But I welcome feedback if others have observed similar findings. And one last thing I want to mention is that we also could learn a lot for patients which do not receive hypocaf in our clinics. So even for patients who are not treated with the hypocaf, we identified some useful insights, such as, for example, allowing the patients to rest 1 or 2 minutes after taking place in treatment. Couch reduces a lot of initial prostate movement. Also, forcing patients to drink too much water increases the chance of bladder cramps. So maybe one should slightly maybe underfill bladders rather than overfill them. So you should take your time when placing the patient on treatment couch, but when treatment is started, one has to perform it as fast as possible. And this is hopefully possible soon if like the Linac companies let us directly move the treatment couch with the Raypilot induced coordinates. So thanks, and I'm happy to answer any questions.